Hello, everyone, and welcome to another SSAT research webinar. I am Saj Khan from Yale University, and I will co-moderate this webinar with Dr. Annabelle Fonseca from the University of Alabama at Birmingham. In today's webinar, we will focus on how approaches of precision medicine apply to GI surgical oncology. Over the next 90 minutes, we will hear from three international experts on precision medicine in pancreas cancer, colorectal liver metastases, and cholangiocarcinoma. We are fortunate to have Dr. Zhenjian Ye from the University of North Carolina, Dr. Nicholas Vaute from MD Anderson Cancer Center, and Dr. Rebecca White from the University of California at San Diego. Each speaker will present for 20 to 30 minutes, and we'll have some time for one or two questions between talks, but we'll be sure to save some time at the end of all the speakers for additional questions. So for the audience, this is for you. Please put your questions in the Q&A feature of the Zoom, and Dr. Fonseca and I will answer your question. We'll ask your questions to the speakers. So let's get started. So the first speaker is Dr. Zhenjian Ye. Dr. Ye is a professor in the Department of Surgery and Pharmacology at the University of North Carolina at Chapel Hill. She's also the Vice Chair of Research in the Department of Surgery and Co-Director for Clinical Research at the UNC Comprehensive Cancer Center. Dr. Ye has done a lot of excellent work on pancreas cancer, and she's identified new molecular subtypes of pancreas cancer that have had effect on clinical management of patients. So our first speaker will be Dr. Ye, and Dr. Ye, we'll turn it over to you.
Sure. Thank you, Dr. Khan, and thank you, Dr. Fonseca, for inviting me, and thank you to the SSAT for this lovely webinar. I'm excited to be here and talk to everybody. So I will talk to you about precision medicine in pancreatic cancer. And if you'll bear with me, I will talk a little bit about the subtypes that Dr. Khan talked about, but hopefully at least I'll first give you an overview of where the field is at this point. These are my disclosures. So, as many of you know, pancreatic cancer is still dismal, but we've actually made a lot of progress over the 10 to 15 years in that the slope we've really steepened the slope in terms of progress in pancreatic cancer. And I think with progress, right, that means that we also have more therapies. And with more therapies, that means that we now have an opportunity to really think about what therapies are going to work best for certain patients. So I think that this is now our golden era for pancreatic cancer and to adopt precision oncology approaches now. So today I'd like to go over different types of biomarkers, gene-based, germline somatic, circulating tumor DNA, which I'm sure many of you are interested and are working on. I'm not going to talk about that much because I don't think that we have a solid way forward yet. We haven't figured out that how to answer that. Transcriptomic subtypes, which is something that's near and dear to my heart. A little bit about protein biomarkers, just in terms of subtypes. Some warnings, and as we are in this technological age, some warnings in terms of all the different technologies that are out there, and then what are the opportunities moving forward. So this applies, of course, to all precision approaches, but really we categorize them into invasive and non-invasive approaches. And for pancreatic cancer, we already have a non-invasive approach, which we try to use, which is not fantastic, CA19-9. And of course, imaging, right, is how we look at response. So what are other biomarkers? There are certainly invasive biomarkers that we are much better at understanding now. One is on the DNA level, and then on the RNA level and the protein level. And I think in the future, we'll be much better at answering questions and looking at precision approaches using circulating tumor DNA or even extracellular vesicles that I know many groups are at the forefront of studying. And so that is all I'm going to talk about today in terms of ctDNA and EVs. So I'd like to switch gears a little bit and just sort of level the playing field a little bit and talk about the types of biomarkers as we're thinking of biomarkers and precision medicine. So there are two categories of biomarkers. One are integrated biomarkers, which is most of what we all work with, right? So we have samples or trials, and we retrospectively look at correlations, and those are integrated biomarkers. The higher bar are integral biomarkers, and that is a high bar because those are used for patient decision making. They have to be in a clinical setting, a validated setting, a CLIA lab or a laboratory developed test. And eventually you have to go to the FDA either for a device approval or some sort of FDA approval in order to use it for decision making, at least ideally. And in the last FDA period, that's what we had to do. So for pancreas cancer, germline mutations in pancreatic cancer are really, really well understood. And so the primary biomarkers that we can use are gene-based biomarkers, and they're germline. And what we know, and the NCCN guidelines suggest, encourage and really mandate that we be doing sequencing on all patients coming through the door, largely for familial reasons, but that also serves a purpose for helping us decide what therapies patients might respond to. So almost all germline DNA mutations in pancreatic cancer are related to some sort of DNA repair mutations. And we know now through many, many trials, this is one of the early ones, that if you have a BRCA2 mutation or any sort of BRCA DNA damage repair mutation, germline, that you are going to respond much better to platinum-based therapy. So you are going to do much better on platinum-based therapy than non-platinum-based therapy. So that's number one in terms of markers that we can already use. Now, there are many, many different somatic mutations, so mutations that occur in the tumor in pancreatic cancer. And the most prevalent are KRAS mutations, which we'll talk about. We just talked about DNA repair defects. And of course, DNA repair defects can also be in the tumor, but not in your bloodstream. So if there are somatic DNA mutations, there are some signals that, at least in pancreas, even if you don't have a germline DNA repair mutation, if you have the DNA repair mutation in your tumor, that you still may respond to platinum-based therapy a little better. And this is a retrospective study, so that's why I made some, I wasn't emphatic about this, but I think that there are some promising effects of this. Now, of course, KRAS, right? I think everybody knows about KRAS. It's really exciting. In pancreas, when there's 90% of tumors that are mutated with KRAS, especially the pan-RAS. This is the Revolution Medicine drug, the pan-RAS drug this is the results that just came out last year, where you see a lot of responses across different KRAS mutations. And now that's gone to a randomized second line trial that we are waiting for reports on. And all reports seem to be very positive in terms of responses. And of course, resistance is happening very quickly. And so we have other things to think about, other precision oncology approaches like predicting resistance or predicting prolonged response. So DNA. How about RNA? So transcriptome and biomarkers. So if we can't use DNA, and DNA, of course, is the cleanest, I think, of all biomarkers in that you have a mutation or you don't. And many times when you have a mutation, if we can develop drugs like KRAS inhibitors or other targeted agents, we can really hit the Achilles heel of these tumors. But if not, there are also opportunities in gene expression. And that's something that we've been thinking about. And I'd like to step back a little bit and just talk about, if we're thinking about new biomarkers, what are the things that we need to think about to bring something to the clinic? And I think that the 4 tenets are really rigor, reproducibility, replicability, and relevance of your biomarker. And as many of you are doing research and are interested in looking at markers, I think that these are really important tenets to remember. And so for us, this is something that we talked about and Dr. Khan mentioned. We have been very interested in looking at the RNA level to see what is the heterogeneity in tumors and whether these actually may be harbingers, essentially, of therapy response. And so about 10 years ago, we were looking at things very agnostically and just thinking about, if we honed in on tumor signals, could we be better? at thinking about the biology and the clinical relevance of these gene expression changes. And so we came up with the names classical in homage to Dr. Eric Hollison's classical subtypes that describe. Notably, they overlap, but they're not completely the same. And I'll talk a little bit about that. I think many times we give the same things to the same biomarker, but using different assays, we get different results. I think that's one of the caveats that I'll cover later. We've reproduced this over time in larger data sets. Others have also reproduced this too, where basal-like subtype patients have a much worse prognosis, shorter survival across all data sets. So we're confident that that is a very consistent finding. Initially, we looked at 2 clinical trials with samples that were available. This is from Steve Gallinger and Jennifer Knox's trial down here, and David Linehan and Andrea Juan Gilliam's trial on the top. And one thing that we looked at was treatment response. And we asked the question, did treatment response vary with these subtypes? And what you can see immediately is the orange basal-like subtype are all pretty much in the unresponsive category. And we get asked this a lot. This is a little bit of a side note, but whether or not there's basal and classical mixtures, other groups have found that with single cell sequencing. We absolutely agree. And in fact, what you can see is in terms of the way that we look at these subtypes, there are definitely mixtures. And what it looks like is the higher your basalness in your tumor, the more resistant you are to FOLFIRINOX. And that's what these orange scatter plot is showing. So as your tumors are more resistant to chemotherapy, your tumor is more basal. And so other groups have really taken the reins and done really elegant studies to look at this. Jennifer Knox has really been heading this from Princess Margaret Hospital in Toronto. And the first study that they published was the COMPASS study. And this was a physician choice, a first line for advanced pancreatic cancer patients. And what they initially found was that basal-like patients who got FOLFIRINOX therapy did not do as well as classical subtype patients. For gem-nab-paclitaxel, they were actually quite similar. And the PASO-1 trial that literally just got published, I think 2 weeks ago now, showed the same thing. And this was a randomized trial between FOLFIRINOX and gem-paclitaxel with metastatic patients. And what you can see is exactly the same trend, where basal-like patients are not responding to FOLFIRINOX as well as they are responding to gem-nab-paclitaxel. And so the differences are much starker between the subtypes when you look at FOLFIRINOX therapy. So that brings us to, well, what does this mean? So there have been many trials now that show that there's therapeutic equipoise between gem-nab-paclitaxel, and FOLFIRINOX. But is this actually truly equipoise when you start looking at these subtypes? In order to answer this question, we need an integral biomarker, right? And so what does an integral biomarker involve? It involves first developing the assay in a CLIA lab, so usually your hospital-based lab, and then making sure there's an indication for it, and eventually you can go to the FDA for usually an IDE before it goes into clinical trial for treatment decision making. So we embarked on this journey many years ago and attempted to make a laboratory developed test or a CLIA approved test because we couldn't really use clustering, which is what you see with all these heat maps, to isolate our calling to a single sample when it comes in, because clustering always depends on neighbors. So Dr. Naeem Rashid, who is an associate professor at UNC in biostatistics, we went to him and we asked him, well, is there a way that we can leverage our knowledge to call subtype on a single sample? And he thought about it and he thought, well, you know what, we can really leverage a previously described method called top scoring pairs, where you're looking only at genes within a sample and figuring out which gene pairs are actually important. And so you could actually do this on the back of a napkin. So you could get your sequencing results. You have these gene pairs, and these are in doublets. If it's high, if it's high or low, it's either classical or basal, and it's just a 0 or 1. And then you have correction factors that summarize into a probability score. And that tells you how basal or classical your tumor is. And so this was our attempt at a single sample classifier. Now, so we have an idea of the model and the classifier. Now we have to bring it to a CLIA lab. And so what we did was we asked Jason Merker and Peggy Gulley here at UNC in the molecular pathology department for their expertise on how to make a assay CLIA validated. And they helped us do that. We benchmarked everything on what we thought was the gold standard, and really the only data that we had, which was RNA sequencing. And we did it on NanoString. We were very fortunate that UNC already had a NanoString machine. It was already being used for PAM50, which is a breast classifier. And so we were able to convert it to NanoString. You can see the concordance, which is the Cohen's kappa score, is 0.87, which is a really high agreement. And so there were only 2 cases that were equivocal or changed in our entire cohort of about 82 or so patients. And so the concordance there was very high. And so that told us that we could now move it into the clinic for decision making. And so what's next? So in order to do that, right, we need to put this into a clinical trial, use it as an integral marker. And this is, I think, where the SSAT audience, and I think up and coming and junior faculty hopefully will be inspired, because these are surgeons. So Susan Tsai, who is at MCW and now at OSU, and Doug Evans, who is chair at MCW, are spearheading this trial where we are testing patients at the time of EUS biopsies. And so these biopsies are getting formalin embedded, getting sent to the UNC hospital lab and subtyped. And this turnaround is within 5 days. And so the results are reported to MCW and also Honor Health, which is the second site. And if you have a basal subtype, you're getting GemNab paclitaxel. So we are waiting to see the results of this trial, but they've done a great job of really spearheading really the process and making this feasible. So we are very lucky to be collaborating with them. So I'm going to switch gears a little bit and talk about caveats, because now we have an assay, right? And there's actually other assays out there that use PIRIS, which is our single sample classifier, something that I'm happy to talk about offline at some point. But there are many, many commercially available assays now, right? And so one question that we actually had asked very early on is, do we really have to be the ones to develop an assay? As you know, academics is incredibly slow. There's a lot of barriers. We're hoping that we didn't have to do that, and we could just really piggyback on some of the commercially available assays. And as we were doing this also became very apparent that different assays, different tests, even though you're testing for the same thing, give you different results. Anecdotally, I think a lot of providers have also found this, depending on where you send your test to. If you send your test to 2 different places, you might get 2 different answers. And so this was something that was very much discussed with our prior administration at the FDA. So what we looked at, we went back to worked with Susan Tsai and colleagues at MCW at the time and looked at Tempus, which is a different platform. It uses an RNA exome sequencing platform, to see if we could actually just order Tempus and look at subtypes that way. And so we were very lucky that Susan actually had the same blocks from the same patient that had Tempus RNA exome sequencing, and also had that we could resequence for RNA to look at concordance. And so to our surprise and disappointment, the concordance was actually not very high, and it was also biased towards one direction. And when we looked at prognosis, and this data set didn't have response, it only had prognosis, there was still prognostic significance, but when you look at it compared to the way that we usually call RNA sequencing, call subtypes by RNA sequencing, you can see that there's definitely a very stark difference in terms of how we prognosticate, and presumably in terms of looking at patient response, calling the different subtypes really matter. We went back and looked and at using the pancreas trial samples so far. So this is within the clinical trial. We again compared the nanostring platform, which is the CLIA calls, to the RNA sequencing of the exact same sample. And you can see we were very relieved, I think, that the agreement was actually quite high still. So we're confident that the RNA sequencing subtypes and the nanostring subtypes are concordant. So switch gears a little bit to protein. So for those of you in the field, there are many groups that are working on IHC or IF or multiplex IF assays to look at subtypes. Agree that that could be a lot easier than trying to have a nanostring in your hospitals, in your hospital labs. So we also worked with Susan Tsai to look at GATA6 IHC, which is generally believed to be a classical marker, and keratin 5 largely believed to be a basal marker. And I will temper all this with saying that a single marker probably isn't adequate. That's sort of the take-home message of this slide. But if you look at GATA6 alone, so these patients would be basal, so GATA6 low, and compared to RNA sequencing, you can see that there's a discordance between how many samples are basal, depending on whether you do IHC or RNA sequencing, which is what we originally did. And these are J1 Lee's data. He's been analyzing the GATA6 and keratin 5 collaboration that we have with MCW and Susan Tsai and Doug Evans. And you can see that prognostically, we just don't see that same prognosis no matter how you look at intensity of staining, whether you use GATA6 alone or in combination with keratin 5, the concordance is actually quite disappointing. And so there are other, I think, difficulties with IHC in terms of reproducibility and thresholding across centers and staining. And so certainly not as straightforward, I think, as we sort of intuitively think. So other opportunities, as I think I'm closing in on time. So other precision oncology opportunities that I wanted to share with you. We've also asked the question, so if these subtypes are biologically important, could they actually have some underlying therapeutic differences that we can look at? And if basal tumors are actually this resistant to chemotherapy, what else could basal tumors be responsive to? And so we embarked on a study with Gary Johnson here at UNC to look at kinases and ask the question whether kinases were actually different between basal tumors and classical tumors. And I'm going to just skip to the next slide. The PCA plot on the left, where you can see lots of dots, the colors are a single line. So that essentially tumors from the same patient. And you can see that appropriately so, all the colors are clustering together. But the pattern is actually very discrete. We were actually surprised how clean this was. The kinome, essentially the global number of kinases, when you look at that, are actually very distinct between basal tumors and classical tumors. And what that suggested to us is that maybe we have some ability to leverage targeted inhibitors for basal-like tumors. And one of the low-hanging fruit that we've been looking at is EGFR, which many of you who are in the pancreas field know that has been largely disappointing, except for some anecdotal exceptional responders. But we wanted to look at EGFR and re-ask the question if we were missing a subset of patients that might have been responsive to EGFR. And our colleagues in Munich had 2 clinical trials, which was a 2-to-1 randomization of gemifatinib, both trials, and RASH, which is more complicated, and I won't talk about that today, or won't talk about the details today, but both trials were reported negative. We were able to look at actually the majority, about 70% of the tumors that were in patients that were on study. Again, if you look at all comers, negative. But if you then subtype them, it looks like only the basal patients are actually responsive to the gemifatinib. And so perhaps we are missing the group that might be responsive to EGFR inhibition. And we found the same thing with the RAS inhibitors. And so classical patients aren't effective, are not benefited by the EGFR inhibitors, but basal patients might. And so that prompted us to work with Ashwin Sumansundaram here at UNC, one of our medical oncologists who designed this trial that is currently enrolling now for metastatic pancreatic cancer patients, where patients are biopsied, subtyped at the UNC Health Lab. And if you're basal, you're going on gem-nab-paclitaxel or erlotinib. So we're excited to see if we are able to find this subgroup of patients that actually might be responsive to a relatively old treatment. So that's it for my talk. I'm happy to take questions either now if anybody has questions or on the panel at the end. Thank you.
Thanks so much, Dr. Ye. We actually do have, that was a fantastic talk. We do have a question in the Q&A. This is from Benjamin Gordon. Does the basal subtype correlate with specific phenotypes in the tumor microenvironment? Example, T-cell infiltration, antigen presentation. And then secondly, does intrinsic tumor subtype act differently within the context of a germline mutated patient? So example, a patient with a basal subtype that also has BRCA2.
Yes, those are incredibly insightful and great questions. So I'll answer the second first. We probably don't have enough numbers for the BRCA2 DDR mutated patient to tell you exactly, but we have never seen that subtype matters if you have a BRCA mutation. We think that my thoughts are that DNA trumps your DNA germline mutation trumps the need for transcriptional subtypes. So even if I went back to the waterfall plots that you saw, there was one orange patient or basal patient that was incredibly responsive to FOLFIRINOX. They actually have a unstable DNA phenotype. So I think that sort of answers your question. Now, the other question, does the basal subtype correlate with specific phenotypes in the TME? The answer is yes and no. And so we are trying very hard to get a paper published that actually sort of uses the same playbook to look at the tumor microenvironment. And so we also have cancer-associated fibroblast subtypes, which actually do tell us how different, whether there's T-cell exhaustion or T-cell activation in the tumor microenvironment. And in general, the basal tumors tend to have more of a suppressed environment.
See any more questions? We could probably go on and then go on to our next talk and then save some time for questions at the end. Thank you so much, Dr. Ye. So our next speaker is Dr. Jean-Nicolas Vauthier, who is professor and chief of HPB at MD Anderson Cancer Center. He's also the Dallas-Fort Worth Living Legend Chair of Cancer Research in the Department of Surgical Oncology. Dr. Vauthier is internationally known for his work on colorectal cancer, liver mets, as well as sort of other fields, and is a wealth of knowledge. He also trained me and is past president of SSAT. And so today he'll be discussing precision medicine strategies in managing metastatic colorectal cancer. So welcome, Dr. Vauthier. Thank you so much.
Thank you very much, Annabelle, for the kind introduction. And it's always a pleasure as the past president to be invited again. So I don't have to have any conflict of interest. And this is a slide that's well known to all of you. This is our main focus of interest is resectability, but resectability has to be taken in context. And I think the most interesting part of this slide is the center of this slide. And when we look at patients, you should look at the biology from the start. The start is, of course, doing a map panel or doing a full analysis of the tumor if we can initially when we see the patient, but it's also looking at the evolution of the patient over the treatment course, looking at imaging response in the context of biology, looking at anticipated margins and how they present, and they present differently depending on the biology and looking at the mutations. So patients are resectable, unresectable. I don't have the borderline resectable here because it's very hard to predict whether the patient is really unresectable unless it's a Swiss cheese liver at the outset. So I will go gradually and deeper in the different layers of knowledge here. For the more junior people, I will talk about the evaluation for resection of CLM. Then I'll talk about the margins, new data, recent data about margins, then somatic mutation beyond RAS, and finally ctDNA and how we use it or we should use it in patients undergoing resection. The evaluation for resection, is done, as I said, with the full mutational panel at the start. But at the start also, we have time and we treat 90% of our patients with preoperative chemotherapy. This allows us really to have a well-defined plan and an understanding of the biology. And this is the scheme of treatment, well known to you, a different way of approaching liver mets. We do less and less major resection. We do more and more parenchymal sparing resection. And in fact, very few now two-stage hepatectomy as presented here. So we have this genetic profiling at the beginning, and then as we go, we look at the imaging, and this gives us an insight into the biology and a pathologic response, and everything comes together when we see patients in our clinics. You see this patient, very different patients. On top of a young patient, in fact, who had a good RECIST response with downsizing, but after the treatment, still no response, really pathologic response on biopsy. The patient underneath had encasement of the middle hepatic vein and the right hepatic vein, and had what we call a morphologic radiologic response with a hyaline transformation of the pathology. And in fact, the patient has mucin pool in the lymph nodes, perihepatic lymph nodes, and no viable tumor cells, and in fact, is still alive today. So if you have RAS mutation, you are more likely, 4 times more likely to have a suboptimal morphologic response. Likewise, you are 3 times more likely to have a minor pathologic response. So these mutations matter, and they really are underneath what we observe radiologically or pathologically after surgery. We've been also very much worried about patients with multiple liver metastasis, and we have seen a slide from Dr. Torzilli or Dr. Macucci presenting resection of 30 patients with 30 liver mets, and as is surgeon crazy, well, there is a place, in fact, and there is a group of patients with multiple liver metastasis who do very well. If you look at patients RAS wild type here, patients with 5 or more tumors wild type, less than 2 centimeters, their survival here on the lower panel is more than 65% at 5 years. Conversely, patients with 5 tumor, 2 centimeter in size, you see the survival at 5 years, it's 37%. So very different. This is a metro ticket. The metro ticket, the further you go, the higher you pay. This has been described initially by Magda Ferro for transplantation for hepatocellular carcinoma based on the size and number of tumor. But you can apply this same tumor burden. It's a continuous observation, and looks at the tumor burden as a continuous variable. And I think it's very important when we analyze these patients. Do margin resection matter? We do more and more parenchymal preserving procedure and resect more and more metastasis, and with minimal margin or no margin. And I have to say, I was very concerned when we started doing this resection to see that, in fact, the margin was 70% positive. If you took per patient basis, we had a very high positive margin, and would this impact our survival? So we revisited the margin question, and really what you need to look at when you look at margins of resection, be it in pancreatic cancer, colorectal metastasis, or other cancer, is whether it impacts local recurrence, not survival, but local recurrence. And you see that, in fact, at our institution, with an R0 intent resection, doing resections R0, R1, with complete resection, using the technique we use with the ultrasonic dissector and the saline cautery. In fact, our local recurrence rate was not higher in patients who had less than 1 millimeter margin compared to patients who had greater than 10 millimeter margin, 8 versus 7%. Interestingly, mutation did not impact the local recurrence rate, and this came as a surprise, and this was a negative fishing trip as part of many negative fishing trips I've had in my academic history. The size of the tumor mattered, and patients who had in multivariate analysis a tumor 5 or more centimeters in size had an increased risk of local recurrence. So the margin don't matter, the mutation don't matter. However, when we analyze these mutations, we find that the intrahepatic recurrence rate was much higher in the presence of co-mutation of RAS TP53. So it's time to go beyond somatic mutation and RAS. And this is a patient we operated more than 10 years ago. And this type of patients makes you really feel really good because you think you're going to do great. You have this great response, this downsizing, and the patient still had an ill-located tumor, but we operated these patients with an extended left hepatectomy and a common duct resection, and you feel great when you do that, and you do your reconstruction, your loop, but very soon after this roux-wide loop, you find a new recurrence, and you're very humble in such patients. And in the era predating the mutation, we didn't understand these patients very well, and we didn't know what to do. And I didn't know what to do at the time. It was 10 years ago, and this patient had a hilar lymph node recurrence going quickly, seven months after surgery. Responded again. I resected the patient again. I did a lymphadenectomy. And the patient, in fact, had a MAP panel a few years later, and I understood the patient. I understood, or I think I understand the biology of this patient a little bit better. It's a patient who responded very well, but it's a patient who also recurred, but that doesn't mean recurrence is a bad thing. Recurrence can be associated with salvage. CTNNB1 mutation are not associated with prognosis. You have on this 50 gene panel, you don't need a 300 gene panel or more to have an understanding of the biology of the driver mutation in colorectal cancer, because they are all present in a 50 gene panel. And you see here, no driver mutation was mutated, and the patient has no recurrence here at 5 years. In fact, there are 6 driver mutations in 5 pathways in colorectal cancer. And these are the pathways, P53 pathway, WNT pathway, MAP kinase pathway, TGF beta pathway, and Notch pathway. And all these mutations, except for APC, adversely affect the prognosis for a reason we still don't understand. And I have been meeting with our basic scientists at MD Anderson, with our basic scientists for each molecule and pathway. I've been meeting the APC gnomes, and they haven't been able to explain to me why APC improved the prognosis, but it seems to be associated with better prognosis. So based on these findings, we developed a grade for patients with metastatic colorectal cancer, resectable and unresectable. And on the left, you have the MD Anderson patients on the one resection. On the right, you have the public domain from Dr. Schultz, public domain data from Memorial, from Dr. Schultz at Memorial. And you see those three grades, grade 1, 2, and 3, very similar, but of course, different overall survival, patients on the right being unresectable. But basically, the grade goes this way. You have a 0 mutation or 1 mutation with APC, you are grade 1. And you're really likely to have a very good survival. In fact, if you have grade 1, grade 2 also, 1 mutation or 2 mutations with APC, and grade 3, 2 or 3 mutation, or 3 with APC. We use now this grading system in our protocol for patients. We discuss for liver transplantation with our colleagues at Methodist Hospital in Houston, and we don't consider for transplantation patients who are really in grade 3. We think the prognosis is really is not good enough to consider for this. We have other criteria, of course. You see, this mutation do not carry the same weight in terms of prognosis, and some of them, such as SMAT4 and FBXW7, carry a worse prognosis. This is survival after local therapy for recurrence, be it ablation or resection. So it's not something that's black and white. I think the mutations are part of our understanding, and they are part of the presentation of each patient's at our institution. As we present patients with metastatic colorectal cancer, one of the first things we present the driver mutation, whether they are mutated or not mutated. We present whether it's a right colon or left colon or rectum, and then the number of metastases, and then the size of the metastasis. This is the footprint, really, of the biology. Now, does it change what we do? Well, it does, in fact, because we look at it, and there are a lot of patients where it's a gray zone. Now, we're going to go ahead and resect the patient with multiple comorbidities, or go for local therapy, for instance, in patients with extensive disease, extrahepatic disease. Are we going to resect extrahepatic disease? We know now that patients who have RAS-TP53 mutation and extrahepatic disease, even resectable, have no long-term survival and the worst prognosis. And finally, at recurrence, re-resection is always a consideration, or transplantation, or chemotherapy. So where should we go? We know that resection can be very good. Re-resection is an important part of this algorithm. In fact, 40% of my practice is now re-resection and redo liver surgery. So surveillance ctDNA, I will briefly touch on this because it's very interesting. It's there. It illuminates also this field in a different light. And you're very familiar with this curve. You're very familiar with minimal residual disease. This minimal residual disease after resectional surgery for colorectal liver metastasis. This MRD interval, which is an interval between the finding of a ctDNA positive in a patient who has and the absence of imaging for recurrence, negative PET scan, negative everything, negative CT, negative MRI. So this MRD interval is a boon for our colleague in medical oncology, and they are certainly testing new avenues in the treatment. Please note that this interval is very different. It's about 6 months. MRD is 6 months after resection of primary colorectal cancer, but our resection of colorectal liver mets, it's about 3 months. We are here in the presence of a disease that's more advanced, and it's different. So we are looking at the same definition, but it's a much shorter interval. And you can monitor the therapy also. Chemotherapy in and of itself can create can lead to a negative ctDNA, and this is something we see in 20% of our patients at our institution. So this is a prospective study we did of 50 patients, about 50 patients who had pre-liver surgery ctDNA using the Guardant. It was the Guardant company that provided this ctDNA assay, and 20% of the patient had a negative ctDNA at presentation and remained negative, and then about 40% presented positive, and they became negative, and 40% remained positive. So the 20% who were negative at presentation were patients who probably became negative with the pre-op treatment, since we treat virtually almost all our patients with preoperative systemic therapy. And the ctDNA clearance really predicts RFS and OS. This is a trial we developed, and I think it's important nowadays to look at de-escalation. We think always about escalating the treatment, adding a new drug. I'm into reducing the number of drugs, reducing the duration of chemo. And here it's an important trial we started, and we're looking now, we almost completely accrued. We're looking at 100 patients for this trial. Patient having a negative ctDNA are being de-escalated post-liver surgery with Xeloda, and patients who still have a ctDNA positive will receive FOLFOX or FOLFIRI as per primary medical oncologist. I have to tell you that it's getting a little bit difficult. We have now a part of our results, and most of our patients are negative. So and that's probably a testament to the quality of surgery and how we plan our surgery, and we try to do a complete resection every time we operate. So this is what you get. You get the blood samples that you get the result of the blood sample from Natera, and you can have the mutations here, but you have to ask for them. And it's a little bit disappointing when you get your ctDNA now. The report are sent as PDF form, and the mutations, the somatic mutations, are not reported. They should be always there. They should be in front of your eyes, and they have to be remembered in the decision making. The variant allele frequency presented underneath in percentage in a semi-quantitative measurement, and we have not been able to correlate this with any outcome. So you're probably familiar with this. I'm presenting this just for bring a little bit of levity at the end of this talk here. The TP53 is really important. You know about the elephants. The elephants don't get cancer very rarely. Less than 5% die from cancer. And not long ago, in fact, in the zoo of San Diego, this was studied really and in more detail. And there are about 3 species with this really different genetic makeup with 20 TP53 allele on each chromosome for the elephant, which is quite remarkable. And I would like to invite you all, since we have the aficionados here listening to this talk, invite you to our colorectal liver metastasis consensus conference in Houston at the brand new Helix Park. This is the QR code. It's co-organized with the University of Zurich. We will use the Danish Zurich consensus method. We'll have an independent jury. We expect 300 attendees. We have 8 panels which will come up with statements, and the panels are going to start working in the next few weeks on the statements and deliver the statement to the juror in January, and the conference will be in February, and there will still be debate in Houston at the Helix Park during this conference when the statement will be presented. Thank you very much for your attention.
Thank you, Dr. Vautey. That was a superb talk. Thank you very much for sharing your knowledge and expertise on this. I have one question I'd like to ask is, do you believe, with the use of biomarkers such as KRAS, BRAF, SMAD4, P53, do you see in the future using these biomarkers to discern someone who might end up having a liver resection or a transplant? Transplants for colorectal liver metastasis are becoming a topic that's being talked much more about in the last 1 or 2 years. Do you foresee biomarkers playing a role in determining resection versus transplantation?
I think that I think that a patient who is the best candidate for transplantation is a patient who is the best candidate for resection, but is unresectable. So these are the same patients in essence. It's the same patient. It's the same patient group. It's this patient group that does well and will not recur. And we have more and more insight into this group of patients. We realize that the patients with grade 1 with 0 mutation or 1 mutation with APC, this is the best group, and they tend to not recur. And you can predict a lot of things, and you can do something palliative, and even when you ablate them, they have lower local recurrence rate. So this is the same group. Now, I think the patients who are going to transplant are patients who really are technically unresectable, but good candidate for resection.
Excellent. Thanks, Dr. Vautey. That's a great answer. There's another question in the chat, but we'll keep on moving along, and we'll save some questions again for the end. And I'll introduce our next speaker, who's Dr. Rebecca White. And Dr. Rebecca White is a professor of surgery and a surgical oncologist at the University of California at San Diego. She's done some exceptional research as a surgeon scientist on various aspects of GI cancer, including for cholangiocarcinoma, which she will talk about today. And as a surgeon scientist, she's also a past president for the Society for University of Surgeons. And At this point, I'll hand it over to you, Dr. White.
All right. Thanks so much for the invitation to speak. I have no disclosures. You know, one of the benefits of speaking last is that a lot of the work has been done for me, and I was not disappointed. I think my esteemed colleagues have touched on some of the basics of molecular profiling. They've touched on some targeted therapies. We haven't talked so much about immunotherapy yet, but I'll get to that. And then, of course, we just had a nice discussion of ctDNA. So my task was to talk about cholangiocarcinoma, which does have a lot of similarities to pancreatic cancer and colorectal cancer. I mean, I think what they all have in common is that these are not trivial surgeries. So a lot of thought has to go into which patients should have surgery and when. They all have issues both with distant recurrence as well as local recurrence, which I think we focus a lot on biology, but sometimes the anatomic issues and the risk affect the risk of local recurrence more, and that can cloud some of the biological issues. A lot of these diseases share some of the same chemotherapeutic agents. All of these diseases are continually having debates over the role of neoadjuvant therapy. Especially in fact, there's really no established role in cholangiocarcinoma. And they all have this sort of similarly moderate tumor mutational burden, with the exception of the microsatellite unstable tumors. And so that's why traditionally these had not responded well to immunotherapy. But I think the main difference is that cholangiocarcinoma is way less common than pancreatic cancer or colorectal cancer, which has made it harder to do the kinds of elegant studies in cholangiocarcinoma that Dr. Ye and Dr. Vote talked about in their diseases. We just don't have the patient numbers or the power. And it's made worse by the fact that cholangiocarcinoma is not just one disease. I mean, it's at least 3 different diseases. As surgeons, we tend to break it up into intrahepatic, perihilar, and extrahepatic because of the unique anatomic issues relevant to each location. But I think outside of surgeons, the medical oncologists tend to lump perihilar and extrahepatic together because of their more similar biology. And where that comes from is studies like this. This is was one of the first really comprehensive profiling studies that was done at Memorial Sloan Kettering, and they looked at intrahepatic and extrahepatic cholangiocarcinoma, and they found that they really were different diseases. Intrahepatic cholangiocarcinoma has really high incidences of a handful of mutations. So IDH1, ARID1A, BAP1, fusions in the FGFR2 receptor. And these are all mutually exclusive, meaning you tend to just have one, and that sort of dictates the biology. Whereas extrahepatic cholangiocarcinoma looks a little bit more like colorectal cancer and pancreatic cancer, with higher incidences of KRAS, SMAD4, and P53. So they have different biology, and yet, despite these differences, most of the historical chemotherapy studies have just lumped them together. Now, as most of this audience knows, there have been a couple of seminal trials of chemotherapy in cholangiocarcinoma that dictate our current practice. One of them is the ABC trial, which compared gemcitabine plus cisplatin to gemcitabine. And not only did it include all kinds of cholangiocarcinoma, it also included gallbladder and ampullary cancer. And this was a definitively positive study. And it clearly established gemcitabine plus cisplatin as the new standard of care. And so that has sort of become the new backbone for any study in advanced disease. Whereas in the BILCAP study in 2019, it looked at adjuvant capecitabine after cholangiocarcinoma or gallbladder resection. This study was sort of positive. I mean, it was not positive in the formal intention to treat analysis, but it was positive. So it hasn't been as widely accepted. And of course, there's still controversy about the role of chemoradiation, especially for extrahepatic disease. So in both of these studies, there have been many post hoc analyses trying to look at whether there were mutations that predicted benefit to one or the other agents, but These mutations have, at most been prognostic, but none were really predictive of any benefit of a particular chemotherapeutic agent. So we don't really have much to guide us in terms of chemotherapy sensitivity. Now, come 2000-ish, there were some game-changing trials in cholangiocarcinoma, as there were in many cancers. So, immune checkpoint inhibitors have been revolutionary in many diseases. They had, I think, already been shown to be beneficial in hepatocellular carcinoma. And then these two trials, I think, are important to discuss, the TOPAZ-1 trial and the KEYNOTE trial, which took the backbone of gemcitabine plus cisplatin and added either nivolumab, which is a PD-L1 inhibitor, or they added pembrolizumab, which is a PD-1 inhibitor. But again, these were all-comer trials, both cholangiocarcinoma and gallbladder cancer. And furthermore, they were unselected. These trials did not have any requirement for PD-L1 status, for microsatellite instability, or tumor mutational burden. So they took all comers. And surprisingly, these trials were positive. So unlike the failed trials in pancreatic cancer and colorectal cancer for all comers, these were more like the hepatocellular cancer studies. So
Dr. White, we're having some audio problems. Bear with us.
extrahepatic. And that is likely because many of the mutations that we know are common in intrahepatic cholangiocarcinoma have been associated with increased expression of PD-L1. And then same thing for the KEYNOTE study. When they look back at the patients who benefited, there was greater benefit seen with higher PD expression. But once again, when they go back to look retrospectively at whether particular mutations were predictive of benefit, they didn't really find anything. And I'm just speculating, but I suspect it's because there are so many different mutations in cholangiocarcinoma that have been associated with PD-L1 that it's hard to show a clear statistical benefit of one mutation over another. So in terms of opportunities for personalization in cholangiocarcinoma, clearly in metastatic disease, I would say it's not just an opportunity, it's really a mandate. I would say it's almost below standard of care to not do molecular profiling in advanced disease, because even though it's called gem-cis-durva in the field. So even though gem-cis-durva is now the established first line, it's not going to work for everyone. And of course, there are toxicities associated, so not everyone can stay on gem-cis-durva forever. So molecular profiling is essential because there's a really high incidence of actionable mutations. This is not a comprehensive list. These are just some of the most important ones from the NCCN guidelines, but these are not rare mutations. So for example, when you look at IDH1, this is 10 to 20% of intrahepatic cholangiocarcinomas. FGFR fusions are at least 10%. So these are not rare events. And then more importantly, the response rates to the corresponding targeted therapies are really meaningful. And so as surgeons, I think the ones that you should at least be familiar with are that IDH1 inhibitors, and again, this is 20% of the population. They have a pretty not very impressive response rate of only 2%, but they did have very significant improvements in disease control and survival because the responses they do get are durable. Whereas FGFR inhibitors, HER2 inhibitors, BRAF inhibitors, and RTK inhibitors, these have had really impressive response rates on the order of 30 to 50%. Now, I'll get into, there are issues with durability with these, but they do have meaningful response rates. So for metastatic disease, a clear role for personalization. And then just as with every other type of cancer, once you have a treatment that's effective in metastatic disease, it sort of automatically starts getting used in patients with locally advanced disease, perhaps with palliative intent, but then you start to see some patients respond, and next thing you know, you have a neoadjuvant approach. And so, people, this is exactly what happened with gemcitabine and cisplatin. So after it was shown to be beneficial in the advanced setting, people started using it in the neoadjuvant setting. And at this year's ASCO, they presented the results of the GAIN trial, which are not in print yet, but it showed a significant improvement in survival with perioperative gemcitabine plus cisplatin compared to upfront resection. So I think that is going to validate the preoperative chemotherapy for cholangiocarcinoma. And so if gemcitabine plus cisplatin works, then why not gem-cis durva? So that's exactly what people have been doing, off trial. And this was a study that was just published in Annals of Surgical Oncology. It's a retrospective study. Again, these were patients that were just treated off trial with either anatomically or biologically borderline resectable disease, and they got gem-cis durva, and not fantastic radiographic response rates. We know that response rates to immunotherapy are not always, they're often underrepresented radiographically, but many of these patients did go on to resection. The pathologic response rates were better than the radiographic response rates, and they even had one complete response. And in this study, they were not selecting patients based on PD-L1, so you can only speculate that perhaps the results would have even been better if they had triaged patients based on PD-L1 levels. So I think that shows that neoadjuvant therapy is coming, and so if you can use gem-cis durva in the neoadjuvant setting, why not use some of these targeted approaches? Now, the ones that are highlighted are all tyrosine kinase receptor inhibitors. They have impressive response rates, but the issue with all tyrosine kinase receptor inhibitors is that they tend to develop acquired resistance. But that's okay, I think, if you're using it in a neoadjuvant setting where you really do just need a short-term response to get someone to resection. So there are several clinical trials that are either in development or ongoing, but even outside of clinical trials, I think you're going to see more and more of this happening, outside of trials, just since these are FDA approved agents. So what about resectable disease? So, I think we haven't even established a role for preoperative therapy in pancreatic cancer. So I think we're a long way away from developing a standard for cholangiocarcinoma, because not only do we have issues with numbers, but we have issues with getting pre-op tissue. It's not as much of a problem for intrahepatic cholangiocarcinoma, where we tend to have mass-forming lesions. But of course, for extrahepatic cholangiocarcinoma, not only they're often not mass-forming, but they also have a lot of desmoplastic stroma. So hard to get good tissue. But luckily, cell-free DNA can sometimes obviate the need for tissue. So as we've already heard, ctDNA can be used for diagnosis. Now, in this particular study, these were all advanced cholangiocarcinoma patients, and we know that the yield of cell-free DNA tends to be lower in localized disease, but they did find genetic alterations that were concordant with tissue in over 80% of patients, which is a very high yield. And furthermore, when they looked specifically at certain mutations, they found that in some cases blood was even higher yield than tissue. And especially given what we know about the heterogeneity within tumors, and especially in patients who might have multiple tumors, so intertumor and intratumor heterogeneity, that you can make an argument that blood might even be a better source of mutations than tissue. So I think ctDNA might become more useful for resectable disease. And I think that as surgeons that, we need to take ownership of this. We should be familiar with these issues and be ordering these tests ourselves. And I know, I don't mean to insult our audience. I'm sure they already know all about molecular profiling, but I think that there are many different competing companies. I think when we're talking about most NGS tests, we're talking about rational panels that have been selected, but it's not whole exome sequencing. I think we all know that fresh tissue is best, but it's really not practical to get fresh tissue outside of a clinical trial. Profiling can definitely be done off of FFPE, but you do need at minimum 20% cellularity, which is often a problem, especially after chemotherapy. And then DNA-based sequencing can miss fusions. And so that is potentially a limitation, although most of the most popular panels do include the most common fusions, such as FGFR. The same as for cell-free DNA. Most of the commercially available tests are just rational panel-based tests, but as Dr. Votay mentioned, the Signatera is different. Signatera is a tumor-informed study that is based off of each patient's unique tumor profile, which allows them to do deeper sequencing over a smaller number of genes and potentially higher sensitivity. So I think, there's a lot of interest in Signatera, and although, it doesn't even come close to the elegant study that Dr. Votay presented for colorectal cancer, there is a nice study that was just published, I think led by the group at Moffitt, looking at MRD and biliary tract cancer, which showed some similar findings, that if you look at the window of 2 to 12 weeks after resection, that a positive ctDNA test was associated with significantly worse survival. Now, how do we use this information? I think, as Dr. Ye said, I think we really don't know yet. There are a lot more studies that need to be done before we can use this to guide adjuvant therapy, but I do think it's coming. So I guess to summarize, I think for advanced cholangiocarcinoma, molecular profiling it's essential. It's below standard of care to not use it at this point. I think one thing we can do as surgeons is if we're exploring someone and we find unexpected metastatic disease, I think it's really helpful and important that we get adequate tissue for profiling. I don't think all the trainees realize that if you just take a liver lesion and send it for frozen, that you really hurt its potential for molecular profiling. The freezing, the way they freeze the tissue, even though in general freezing is good for preserving RNA and DNA, the way they do it when they do a frozen section is not optimal. And the ice crystals make it hard to do IHC down the road. So if you have more than one lesion, I think it's a good practice to send one for frozen and then send one dedicated sample for FFPE. For localized disease, I think molecular profiling is basically already here and coming. There are several planned and ongoing trials, and I think we're going to see more and more incorporation of immunotherapy in the neoadjuvant setting. And I think for all stages, ctDNA is going to become part of our practice. So that's all I've got. So I think I regained some time and we can now answer some questions.
Thank you so much, Dr. White. That was an incredible talk. And cholangiocarcinomas are fascinating, right? Because they're so heterogeneous, but at the same time, there are so many potentially targetable mutations. Coming back to your what you said about ctDNAs, how do you see that evolving sort of in the short term, or what's your current practice as far as using it to, say, during surveillance, how to guide adjuvant therapy, perhaps?
Yeah, I think the way I've been used, I do routinely send it. I think it is a little bit controversial because sometimes, it's a good question. What do you, I think this is really relevant to the question that was put in the in the Q&A box. What do you do when you have a positive ctDNA, but there's nothing on imaging? Is it just creating anxiety for the patient? But I feel on the most part, I think most patients do want to know. And I think it helps you sort of gauge the intensity of your surveillance. And then I think particularly when you've got maybe a marginal patient who's on the fence about whether or not they want to pursue adjuvant chemotherapy, I think that's where it's really helpful. I think if you have a positive study, that will usually convince them. If you've got someone that's kind of marginal performance status and you have pretty good pretty good pathology, maybe you just do a watch and, an active surveillance plan.
Yeah. Thank you so much. If anyone has questions, feel free to put them in the Q&A and we can ask them. But if I could open that question up to the group, Dr. Bothe, it was initially directed at you, but if we could have your sort of how you'd approach that. The use of ctDNA, I'll repeat the question, the use of ctDNA for surveillance. So for instance, a patient who converts from negative to positive during surveillance, but has no new radiographic findings. Does that prompt escalation of the chemotherapy regimen or to restart a therapy, for example, or just continued surveillance? You're on mute.
He's typing.
In principle, you don't treat non-measurable disease. So, however, I like the answer from Rebecca. You're on the fence regarding adjuvant therapy and you have a ctDNA positive, then you give the adjuvant therapy when it's proven, again, because there's controversy regarding the benefit of adjuvant therapy. But I think if the adjuvant therapy is not the question, if it's as part of the follow-up, let's say 1 year after a resection and your ctDNA comes back positive, and then all imaging studies are negative, then you're going to shorten your surveillance for sure, and then you're going to try to enroll the patient in a vaccine trial or in a new drug trial. Our medical oncologists are very excited about it. They see it as a window of opportunity to treat minimal disease and maybe change outcome. But I think it's a hope, and I'm wondering, what's the end point, and I still would like to see a good endpoint attached to these studies.
Thank you for that. I don't see any other questions. I have one for you, Dr. Ye. You mentioned the basal type and potentially EGFR inhibitors. Is there anything about sort of increasing the chemosensitivity? I feel like I read something about it a little bit ago, but maybe not enough, about increasing the inherent sensitivity with, I feel like TGF beta, or I feel like there are some studies in this space, but I'm not, but it'd be lovely to kind of know what the data is. And
so I think you're referring to the study from Brian Wolpin, and I think Andy Aguirre was part of that study out of Dana-Farber, where they found that a lot of people in the sort of basic scientific translational setting have done really elegant studies to show that there's likely a plasticity between the two subtypes. And I think if we simplify things, it's basically a poorly differentiated versus a well-differentiated tumor. It's not exact like that, but simplicity wise, one could think about it that way. And so the question that group posed was that, can you essentially redifferentiate a poorly differentiated tumor using a TGF-beta inhibitor and make it chemosensitive? Now, I think that there were more, the TGF-beta inhibitor had more, I think, mechanisms than just tumor plasticity. So I think that the trial was not as positive as one would think. There were some findings in terms of the tumor immune microenvironment that were initially thought to be also affected by the TGF-beta and ultimately weren't. So that plasticity and that switching for that trial, I think, did not really pan out to be what we thought it would be. But it was definitely really exciting at the time. Has it stopped people from thinking about it that way? And I think the answer is no. One good example is both Anupriya Singhal in Thomas Tamelis lab and Julian Dilley in Andy Aguirre's lab last year published 2 back-to-back studies on the KRAS inhibitor. And so this was actually on G12C in genetically engineered mouse models that showed that the single cell sequencing, and when you really look at cell level populations, that the KRAS inhibitors are actually getting rid of the basal expressing cells. Mm-hmm. And now you have a classical population left. So eventually, could KRAS inhibitors actually be one of those chemosensitizing or resensitizing agents? I think time will tell, but it's something that's of interest. And I think Anupriya Singhal actually had a very nice sub panel that actually showed. So their studies were on G12D inhibitor in genetically engineered mouse models. I misspoke. But the Anupriya Singhal's paper actually had a panel of a patient with a liver metastases treated with a G12C inhibitor that looked poorly differentiated pre-G12C inhibitor treatment, and then looked very well differentiated post-G12C inhibitor, suggesting that there's probably something there that we should be thinking about. But great question.
Thank you. Dr. Khan, any questions?
I guess I can ask one question to Dr. White. So Dr. White, so you nicely put up for cholangiocarcinoma some of the important mutations that we should be looking at when patients have their tissue resected or biopsied. Do you think like genes such as IDH1 are the driver mutations, or do you think they're passenger mutations? And do you think we should be looking a little bit harder, or thinking about cholangiocarcinoma perhaps in a different way than some of the common genes that we see mutated?
Sorry, my internet decided to freeze right then.
Oh, sorry. I was just asking about, do you believe that some of the genes for for cholangio are driver mutations or passenger mutations, or do we have to look harder for, something that's more of the silver bullet here to go after from a systemic perspective?
I think there's more than one question in that, which are all good, but so whether it was the true driver mutation, I don't know the answer to that, but I think I suspect they are, though. The fact that I think the mutual exclusivity, I think, tends to imply that there's more, that there really must be a functional role to that mutation, and that it's not just a secondary mutation. So I think especially IDH1 probably is a true driver. It's obviously important functionally based on the outcomes with the inhibitors. But I think what I don't think is fully understood is why does cholangiocarcinoma respond so well to checkpoint inhibition when so many other tumors do not, with similar mutational burden? So I don't have an answer to that, but I think that it's known that IDH1 mutations are associated with increased PD-L1 expression, as are some of those other mutations mentioned.
Excellent, Dr. White.
Perfect. I don't see any more audience questions, so I think we'll close out. This was an amazing talk. So thank you to all our fantastic speakers for their presentations, and thank you to the audience for staying on and staying engaged and asking questions. And so, I mean, this is a key topic, right? It's something that all of us need to know about and will become increasingly important over the next sort of several years. So on behalf of SSAT, thank you to all our speakers and our participants. And this will be recorded and on the website for future. So feel free to review it in the future. And definitely join us again for future programs. SSAT has several really good webinars that are up on the site that are upcoming. So thank you to everyone and have a great evening.
Thanks for
Thank
organizing.
you. Thank you very much, Saj and Annabelle, for organizing.
Yes, ditto. Thank you very much.
Bye.
Bye.
Thanks to the speakers.